Hi, my name is Alexander Phan, and I'm a fourth-year medical student at Arrowhead Regional Medical Center. I'll be presenting a rare case of combined antithrombin 3 deficiency and catastrophic antiphospholipid syndrome. I would also like to accredit my collaborators, Aldin Malkoc and Dr. Debra Craig. This is a case of a 45-year-old female who presented with left flank and generalized abdominal pain for one day. She also reported difficulty urinating and left lower extremity pain that worsened while walking. Her past medical history is significant for neurofibromatosis type 1, renal tubular acidosis type 2, history of coronary artery disease, peptic ulcer disease, non-diabetic gastroparesis, and Takotsubo cardiomyopathy. Her past surgical history was not contributory. Social history included a 15-pack-year tobacco smoking history. She denied alcohol consumption and illicit drug use. Family history was also not significant. Her current medications included amiloride, metoclopramide, pantoprazole, spironolactone, sodium bicarbonate, and iron sulfate. She has an allergy to erythromycin. Initial vital signs showed an initial temperature of 97.4 Fahrenheit, 121 beats per minute pulse, 26 for respiratory rate, blood pressure of 140/101, and 99% oxygen saturation on room air. Her physical exam was most notable for a 3 out of 6 systolic murmur heard best at the right second intercostal space, absent bowel sounds, diffuse abdominal tenderness, absent pulses in the left foot, and both feet were cool to the touch. Initial labs were also notable for a leukocyte count of 40,100, platelet count of 1,098,000, bicarbonate level of 11, and lipase of 1,808. A CT abdomen with contrast was performed. On the left panel, we can see the filling defect of the descending thoracic and abdominal aorta, wedge-shaped defects in the spleen and liver suggesting infarcts. On the right panel, we can see inflammatory change in the pancreas suggesting pancreatitis and filling defect in the aorta. The left panel here shows a lower extremity CT angiogram demonstrating a thrombus in the left common femoral artery. On the right panel, we have a CT of the head that showed right cortical infarcts. Given our patient's clinical presentation, lab findings, and imaging, we had low suspicion for an infectious etiology for her presentation. Consequently, we pursued a thrombophilia workup. We found elevated anticardiolipin IgM levels, low protein S activity, antithrombin 3 deficiency, and lupus anticoagulant positivity. The remainder of her thrombophilia workup was negative. With regards to her diagnosis and management, given the patient's multiple organ thromboses, clinical picture of leukocytosis, thrombocytosis, and physical exam findings, positivity on thrombophilia workup, we diagnosed her with antiphospholipid syndrome. Additionally, with her low levels of antithrombin 3, this further corroborated diagnosis of antithrombin 3 deficiency. Thus, we started the patient on heparin and bridged her to warfarin for anticoagulation. 6 days later, the patient experienced hematemesis, hematochezia, and intractable abdominal pain. She was also found to have a supratherapeutic INR of 10.8. We pursued a CT of the abdomen and found free fluid in the left paracolic gutter in the pelvis, which tracked from the abscess cavity, clinically correlating to her peritonitis. She underwent immediate ileocystectomy with ileocolonic anastomosis. This table shows the support criteria for diagnosing antiphospholipid syndrome. Our patient met the laboratory and clinical criteria. She had the arterial thromboses. She was also positive for lupus anticoagulant and positive for anticardiolipin IgM. We also suspected that our patient's supratherapeutic INR was likely due to poor gastrointestinal absorption secondary to ischemic bowel. Thus, we transitioned the patient to enoxaparin for anticoagulation, and at 3 months follow-up, she did not have any further thrombotic events. Clinicians should consider poor gastrointestinal absorption of warfarin in patients who fail to achieve adequate anticoagulation or happen to have INR instability. Recognition of treatment failure and prompt changes in management are very crucial in preventing worsening patient outcomes. Thank you for your time.